Hello. Recently, LV diastolic dysfunction has attracted a great deal of attention. Diastolic dysfunction, or we can say the inability of LV to relax and fill properly. This dysfunction occurs in a variety of heart diseases, and it often predates the decline in LV systolic performance. Terminology you might heard of, heart failure with preserved ejection fraction, is a kind of diastolic heart failure. Normal LV diastole can be divided into 4 discrete periods: relaxation phase, early rapid filling, diastasis phase, and atrial systole. And you have to remember that in first 3 phases there is LV filling, but there is no active contribution from atrial contraction. It is solely due to relaxation and MV opening. So what we have to do is take a good apical force chamber view and put pulse wave gate on mitral valve leaflet as shown in the demonstration. This way we will get a typical mitral inflow pattern consisting of E wave and A wave. E wave represents early gush of blood from left atrium to the left ventricle, which is early diastolic filling, and it is kind of passive movement of blood. It is not because of atrial contraction. When atria contracts, there is another gush of blood from left atrium to the left ventricle, which represents wave A. With that in mind, if there is abnormality in E wave, it means LV relaxation is impaired. And if there is abnormal A wave, it means atrial contribution towards the diastolic filling of left ventricle is impaired. If you look at this spectral Doppler, you will notice a smaller E wave and a taller A wave. It means the impaired LV relaxation, as there is relatively smaller contribution of early passive diastolic filling, and there is a larger contribution by atrial contraction. So we can say here it is impaired relaxation of left ventricular myocardium. This is also known as grade 1 diastolic dysfunction. If we look at this spectrum, it looks like a normal configuration of EA wave or normal mitral inflow pattern. But if we apply Valsalva maneuver on the patient, the spectrum got like this. This is a case of grade 2 diastolic dysfunction. So if we find a spectrum with EA ratio less than 0.8, then it points towards the grade 1 diastolic dysfunction. But if it is normal, it is greater than 0.8, then we should do Valsalva maneuver to evaluate and possibility of grade 2 diastolic dysfunction. If there are limitations to Valsalva maneuver, or there is still ambiguity about the diastolic dysfunction of left ventricle, then we should go for tissue Doppler approach, in which we will apply the gate over septal annulus. There we will get 2 negative waves, E prime and A prime. If the velocity of E prime is less than 8 cm per second, then it points towards the grade 2 diastolic dysfunction. If we look at this spectrum, we are getting a taller E wave and a small A wave. It means there is a rapid early diastolic filling of LV, but there is little contribution from left atrium. In other words, LV volume is restricted. It is allowing early diastolic filling, but it is not allowing another gush from the left atrial contraction. So there is a small A wave. This is an example of grade 3 LV diastolic dysfunction or restrictive type diastolic dysfunction. And here is the summary of different grades of LV diastolic dysfunction by POCUS 101, along with few additional helpful criterias. I hope this video has helped you understand basics of LV diastolic dysfunctions. Thank you.